Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, and I have the pleasure of having DeLon Canterbury on today. He is a fellow pharmacist. We've had a lot of pharmacists on lately, and he thinks a little bit along the lines of how Janet and I do. If you followed us enough, we believe that a lot of medication that is prescribed doesn't need to. People don't need to be on them long term. So DeLon actually has his own medication consulting business where he helps to de-prescribe medications, working with the patient and the patient's prescriber to get people off medications. So if you're on any medications and you don't think you are questioning that, and you're wondering how to get off medications, this podcast is for you. So tune in until the very end. So DeLon, welcome to our show.
No, appreciate it. Thanks for having me on. How's it going?
Hi, it's going great. So tell us a little bit about what you do and what de-prescribing is.
For sure. So I am a board certified geriatric pharmacist as well as the founder of Geriatrics. And so we focus on providing de-prescribing action plans for some of our over-medicated seniors. But not just that, we also talk about some of those social barriers we support with looking for financial resources and advocacy, and really focus on the education around the medications and how we can consider other alternative treatments to help people get to their healthcare goals. So we've launched in 2020, and we also employ the power of pharmacogenomics. So we also use genetic testing for all of our patients who qualify with our de-prescribing action plan. So as you know, we have way too many seniors being sent to the ER for preventable side effects and drug errors. And so we got to do something to hit that number. And I feel we're not doing enough in our healthcare system to leverage pharmacists and de-prescribing advocates, which is what I aim to do with our de-prescribing accelerator program.
So tell us a little bit more about the de-prescribing accelerator program.
Yeah, for sure. So we have created, and this has really came from my past 5, 7 years in pharmacy, of really teaching like-minded clinicians who are passionate about stopping harmful meds on how to incorporate some of our pharmacist brain and use that to advocate for patients. So it's not all about you need to know all these meds. It's more about how are we showing up as advocates, asking questions like, are you on more than 5 meds? Have you had any changes in side effects? Have you had any more falls lately or changes in mood or pain? Just asking probing questions to empower not just the patient, but also the caregiver. So, our de-prescribing accelerator program is actually CE accredited. It's intended for prescribers, so physicians, PAs, NPs, pharmacists, as well as social workers who are looking to really employ and implement de-prescribing within their business. So we're doing this over the course of 3 months. We're actually going through our final cohort of the year right now, but we have another one we are currently interviewing for that will start in March of 2023. So it's a hybrid of didactic learning, where you will learn tips for opioid de-prescribing, dementia de-prescribing, genetic testing as well. But we're also going to touch on how we can help you, the clinician, leverage this into a sustainable business model. So you're getting a mix of coaching as well as clinical de-prescribing that's evidence-based in practice.
So tell us a little bit more about this CE program. Is this available is there more information on your website about this?
Yes, the best way to find out more will be on my LinkedIn page. If you look up my name, DeLon Canterbury, or search Geriatrics on LinkedIn. On my homepage, there's actually an application link to apply for it, as we do have a pretty rigorous application process. We really want passionate people who want to make this sustainable and lead with a heart of service, not with just trying to make quick money. It doesn't work that way. You have to really have a passion for this. So you can find out more on LinkedIn. Just look up DeLon Canterbury or Geriatrics, and you'll find an application on my homepage.
So can you give us some examples? Like, what is the most common medication or maybe class of medications that you de-prescribe?
I would say one of the not necessarily easiest ones, but one of the more common ones are proton pump inhibitors. as well
Hmm.
as certain over-the-counter medications that may be used inappropriately, and some multivitamins that no longer have any clinical utility. So I would say proton pump inhibitors are what I see most. People had a little issue 10, 15 years ago, and they've been on that omeprazole for the next 20 years, right? So
Right? We see it
that's
all the
something,
time.
yeah, you see it all the time, and no one's questions it. So it will take a bit of a tapering strategy with some of those. Some people get rebound, acid reflux, which is what they were treating. Some people don't have any issues at all. So it does depend on how the patient responds, but I would say PPIs can be very problematic as we age because of the nutrient depletion. You're not getting
Right.
magnesium, you're not getting other vital nutrients, as well as the gut microbiome is completely trashed now. Like we've really reduce the acid secretion. And so the bacteria that's good, that's meant to be in there, that actually is linked to immune function and cognitive impairment and other life factors, that's all wiped out. So there needs to be a bit of a process on restoring some of those healthy gut flora. And as we age, can become more susceptible to harm. So very, very important to get those tapered off.
Yeah, we have talked about that multiple times on our podcast about PPIs and just the damage that they've done to so many people. And when you look at the package insert, I believe you can help me out with this, DeLon, but I believe they're really still only indicated for 6 weeks. But yet, like you say, 20 years, people are on these for 20 years at a time. And our stomachs are meant to be acidic. If you have chronic problems with reflux, there's other issues going on. You know, don't just wipe out all the acid in your stomach because the acid is meant to be there for a reason. So,
Right.
yeah, and I will say that I've never really experienced somebody that's been on chronic PPIs. I haven't experienced that it's ever easy to get off of them. I mean, but you say it is. You've seen that before.
Some people can cold
Yeah.
turkey it because truthfully, there probably wasn't really an issue to begin
Right.
with.
True. Right.
But no, most you do kind of have to taper a little bit. And sometimes you can use like as you're weaning down on one, you could try another for temporary purposes, like maybe Tums or a ranitidine or something like that, or a H2RA or a histamine blocker, just again for a trial while they're
Short
getting
term and
off of
short
the drug.
term.
So, we're not going
Right.
to repeat the problem and keep that on. So
Yeah.
it could be a tool or a strategy to employ. But yeah, no, it's not easy for sure. It's definitely not easy, and it's subjective to the patient.
So how did you initially get into this? Usually there's some kind of story or a aha moment where you did this, or did it just kind of progress over time?
For me, I was a pharmacy manager with Walgreens after graduating from pharmacy school in 2014, and after 3 to 5 years of leading a team to basically tell people to take 90-day scripts of meds they don't need, I started getting a little bit frustrated with our health system and angry at seeing how many seniors in this rural setting that I was in Henderson, North Carolina, were just falling through the cracks, right? I mean, social stuff was missing, transportation, all these social barriers, as well as me trying to navigate getting you the best coupon because you're in a coverage gap and your copay is $1,200.
Right.
So it's like we're putting all this money into drugs. We're making people pay for it who can barely afford it on a fixed income, who get $700 a month to live on from social services, social security, and you want to come to my counter and I have to fix all these problems in 5 minutes before I have to go do a flu shot or a COVID shot or whatever BS metric that wasn't really helping the patient. So
Right.
I got depressed. I'm not saying anyone, I'm poo-pooing the job, but it was something that spiritually wasn't in alignment with me. So I felt, okay, what if I create a concierge package that can hit some of those main issues with a med review, right? And just give this concierge approach to care and kind of just flip the script on how we're approaching our pharmacist intellect, right? Because we're all experts on the drugs. So
Right.
that that got me in the space of volunteering and working with senior facilities, speaking at nursing homes, attending caregiver conferences, and it opened my eyes to a whole world of everyone needs a pharmacist, right? Especially in the geriatric space. So for me, it was seeing what I was seeing in retail. And then secondly, my grandmother actually had dementia. And while she was in a nursing home, she was inappropriately prescribed ziprasidone, an antipsychotic, with no history of bipolar or schizophrenia. So they put her on an antipsychotic. Her dementia symptoms worsened. Her behavioral symptoms got so bad they had to kick her out. And my parents had to move her in from from New York to Atlanta, where my parents reside and where I grew up. So I wasn't quite a pharmacist yet, but having to see the hell my parents went through as caregivers and full-time parents, full-time employees, uh, I don't want people to relive that. I don't want people to experience what my grandma Mildred did. So that always stuck with me. And I felt, how many more people are falling through the cracks or dying and it being mislabeled, or being forced into a nursing home because of one pill, because of one pill. So
Right.
that was my mission behind geriatrics. And that's honestly, our ethos when we treat all of our patients is to treat them like they're your grandmother.
So give us the most extreme example of medications that you've de-prescribed, like multiple medications for a patient, and how much money you saved them. Do you have any kind of examples of that?
I would say our hallmark case was our very first client who, when we found her, was on 36 medications. It was a 70-year-old woman. Yep, crazy.
Wow.
36. 36 and she was essentially described as a walking zombie. She was unresponsive. She was kind of wasting away in her caregiver's home, wasn't really all there. And the caregiver was distraught because she didn't want her, golden years to be spent in this kind of zombie state. So this woman had multiple prescribing cascades, multiple duplicate therapies from two or three different nursing homes she was in and out of. Um, and no one wanted to touch the meds. No one wanted to touch the meds. So she was seeing a neurologist, she was seeing cardiologists, specialists, and PCP, and there was no crosstalk. So all these meds were causing issues. There were about 7 prescriptions that were all involved that led to the worsening of her dementia or cognition. And they were because she was suffering from anticholinergic toxicity.
Yeah.
So she was on Seroquel, she was on Benadryl, she was on Tylenol PM, she was on Tropium. She was on like everything that's bad on the beers list for anticholinergic toxicity and having mild cognitive impairment. So we were able to successfully de-prescribe her over 2 months. Some of them cold turkey, some of them you had to taper, like the Seroquel, we were able to taper. Um, uh, Over 2 months, we were able to get her down to 8 prescriptions, which is amazing. And that she's doing
Wow.
better. I called them maybe like 2, 3 weeks ago or a month ago, and she's doing great. She was at the beach this summer. She's living her life. She's doing her thing. She's back. Her grandma was back. So it was something that was not only my biggest win, but it was proof that this was the calling I needed to serve in my career and in my field.
28 medications you de-prescribed, basically. Your help de-prescribe.
Yeah.
You have any idea or just estimate about how much that was costing per month?
She was on Medicare, so a lot of her meds were fairly inexpensive, either between, no charge to $1.20, 3.60 or whatever. So the price was, somewhat negligible, but with all those meds, she, as you can expect, wasn't even as compliant. So she was hoarding meds. She had stuff from years ago. So I don't really have a cost for you. I do know that because of this testimony, we ended up giving a report on this very same patient in the court of law. And so the ugly side to this story was that her family was actually going to involuntarily commit her into a nursing home, into a memory care unit, because they were convinced it was her, not the pills. This woman would have been paying close to 11K a month. So in terms of cost savings, we have saved them well over $250,000 in the past 2 years because they would have otherwise been forced into a nursing home and be paying out of pocket for that. So I can tell you that cost savings.
Wow. And is it safe to say that the medications was costing Medicare thousands of dollars per month?
Yeah,
Yeah.
absolutely. Yeah, it's a
Yeah.
waste of taxpayer money, and yeah,
Right.
absolutely.
Right. Wow. Wow. That's quite a story. So, and now she's independent now.
Well, she lives with her daughter, but she's good.
Yeah.
She's on still 8 meds or 10 meds.
Yeah.
I think she added one or two more on. Uh, but overall, she's fine. She's great.
Yeah. So what is your how does if a patient or a family member of a patient or a caretaker has a question about deprescribing, what's the best place to look? I mean, how do you go about this? Do they ask their doctor about it, or
Ask your
do they just ask
pharmacist.
their pharmacist? Yeah.
Yeah, ask your pharmacist is still probably the easiest person to access, even though that's with a grain of salt, given it's COVID season, it's flu shot season. But they're the fastest person to talk to objectively about whether you should be on some of those or not. Now, not all of them are going to be trained as geriatric pharmacists. So it does help to have someone who specializes in understanding senior care and the pathophysiology behind it. But even so, if your loved one is on 5 or more meds or 7 or more meds, we know that statistically there's an increased risk of harm, hospitalizations, drug interactions, polypharmacy, all that jazz. So with that risk factor in mind, you're going to want to talk to your pharmacist first, try to get an objective opinion. And then immediately, if you're in that category, start messaging your provider in MyChart or whatever system you use and say, what can we do to safely get Louise off of all these meds, and just make that a continuous process. It's not going to be a one-time thing. You need to ask this on every visit and have a targeted and consistent approach to taper these meds and stop some of these meds that are inappropriate.
Yeah, I think that's a really good tip. Thank you for that, because one of the things is it's dynamic, and one of the things is in our healthcare system, because of the way most providers don't have enough time or don't take enough time. I don't like making the excuse not having enough time. It's like they make the choice to not have enough time, usually because of insurance contracts that they have entered into. Um, and so it's easy when somebody has a complaint like acid reflux, they just prescribe another drug, when in
Mhm.
reality, it might be a diet lifestyle issue. And so
Mhm.
it's easy, pharmaceutical companies and insurance companies have made it pretty easy to prescribe a drug instead of really going over lifestyle changes. So it's really easy
Yeah.
at almost every visit to add another drug to a patient's regimen. Is that correct?
Oh yeah, it's what they're trained to do. It's what our system is trained to do. It's geared towards a fee for service model. It's easier to prescribe than not. That's
Right.
Western medicine, right? In its
Right.
core. So we have to really tackle this medication mindset that has been forced upon the American community from direct to consumer marketing of all these pharmaceuticals and truthfully, our education prescribers don't know anything about de-prescribing. They're not taught about de-prescribing. They're taught about prescribing and diagnoses and have their own specialties there. But America's behind. I mean, when I look up de-prescribing, it comes from other countries, Canada, Australia, Odin. There's European de-prescribing networks. We just started our very first de-prescribing network in 2019 in the US. So
Wow.
we're years behind, but we're starting to pick up steam. So I'm going to give us some credit. But the truth is, our systems are so fragmented. It's very difficult to, well, it's difficult from a policy standard to really make this the standard of care. It can happen, and it does happen within our own worlds. Uh, my job is to make it universal.
Yeah, it's just something we have to all be paying attention to, because what we're doing is not working. We can't continue to just keep putting people on chronic medication after chronic medication. That's
Right.
just, and I don't care what studies quoted, I don't care what pharmaceutical company says. It's just not long term. It's not good for patients to be on multiple drugs like that. I just
We
really
we
honestly
don't
believe
even
that.
we don't even have evidence like past 3 years for most medications that people are taking. And then we're using data from the 70s and 80s for drugs grandfathered in and assuming people of different ethnicities and cultures will respond the same. We're not even using genetic testing the way we should.
Right,
So
right.
how can we just
That's
assume that
true.
these meds are going to be, universally great for everyone? They're not. So, and I'm not poo-pooing meds. We need meds. I get that,
Yeah,
but there
right.
needs to
I
be
mean,
a,
yeah.
a more judicious approach on how we're prescribing. So there needs to be a change in prescribing habits. There needs to be a change in policy incentivizing de-prescribing. There needs to be a concerted social effort on educating communities about the power to de-prescribe because they don't even think to ask they can get off some of these meds, right? That's a whole other issue in itself. So there's a compounded multi-layer issue with multiple competing priorities for different players. But even so, if I see that our own VA health system is successfully using de-prescribing, then why can't the rest of us do it? We can. We just choose not to. So that's
Yeah,
my
and
take.
I think it's instrumental that pharmacists have to get involved in this process.
Yeah.
We're really, we're the drug experts, right? So we're the ones that really have to get involved. And I think first and foremost, it goes with us educating the patients.
Hmm. Yeah.
We're the ones that see them more than any other healthcare professional. We need to educate them. It's like, do you really need to be on these drugs? And I know, as a pharmacist myself, we don't do traditional pharmacy, but we do a lot of hormone replacement stuff. And but we'll get patients that call in and they're on a statin or a blood pressure medication or whatever, and it's like, well, if you make some lifestyle changes, you might not need to be on these medications anymore.
Hmm.
And
Yeah.
we just have, as pharmacists, we have to continually remind patients about that, because we're the only ones that are probably going to.
Absolutely. I mean, yeah. I mean, it can't really be said any better. It's again a mindset shifting that we need to prioritize. But a lot of it starts again with a conversation and a trusted provider who has their best interests at heart.
Awesome. Well, DeLon, you really helped us realize our goal today of educating and empowering individuals to take charge of their own health, and pharmacists are part of that team. Tell us a little bit about what do you have a passion for?
Apart from senior care and patient advocacy, I really enjoy playing the cello, and I really enjoy playing video games and hanging out with my dog Kaya, who is in here sleeping. But travel has probably been my number one passion.
Awesome. Love it. So tell us, I'm going to stream your website here, and tell us a little bit about your website and how to get a hold of you.
Yeah, the best way to reach me is checking out geriatrics.org, Geriatrx as an x-ray.org. You can also check out our LinkedIn page. We have tons of content. The best thing you can do is binge some of our red pill versus blue pill. We have a video series talking about de-prescribing, and we go live every Thursday at 12 p.m. Eastern. Again, talking about the issue, talking about how pharmacists need to be embedded into non traditional roles as experts, as consultants, and can really move the needle on stopping 750 seniors being hospitalized every day in this country.
Wow, that is a powerful number. 750 every day.
Every day.
That is very powerful. From drug interactions, basically, or drug
Drug
side
interaction
effects.
from drug side
Yeah.
effects. Yeah.
Wow, that's incredible. I mean, that's a big problem, and as pharmacists, we can help fix that. So, thank you so much, DeLon. I really appreciate you being on. Let's stay in touch, because I'm sure you got a lot of other subjects that we could talk on.
Love it, man. Have a great
All
week.
right.
Thanks for your time.
All right. Well, thank you for tuning in to Health Solutions with Shawn and Janet Needham. Monday, our regularly scheduled podcast, 12:30 to 1:30 Pacific Standard Time. We will have Dr. Brad Brown on. We've had him on before when he was a resident physician. Now he has his own practice direct primary care practice. He's going to be telling us how he is helping patients, and he and his brother helped develop a software specific for direct primary care doctors. So any doctor, if you know is in direct primary care or looking to go into direct primary care, please let them know. Monday, 12:30 to 1:30 Pacific Standard Time. DeLon, thank you today.
Yes, take care.
All right, bye-bye.